So, respected doctor delegates, at the outset, I thank the Reddy Labs for giving me an opportunity to speak on changing horizons in the gastrointestinal disorders. So, let us focus on the current burden of the gastrointestinal disorders. See, they are responsible for about 2 to 5% of all primary care visits. Abdominal or the epigastric pain is very common, not only in the pelvic ulcer disease, that is the combination of your gastric and the duodenal ulcers, and it is as high as 81% of the patient profiles, and there is a persistent and the recurrent, and hence reduce the quality of the life also. See, the GERD and the dyspepsia are mostly combined. So it's sometimes it's very difficult to differentiate between the GERD and the dyspepsia. See, acid peptic disease is not just a one disease, a common disorder affecting the millions of the people worldwide, more so in our Andhra people. The symptoms are very common, like the epigastric pain or retrosternal burning sensation and reflux. The risk factors are the maximum excess usage of the NSAIDs, smoking, alcohol consumption, and the polypharmacy, steroid usage, treatment. So mostly the dietary restrictions, some lifestyle modifications. These two are very, very important to reduce the GERD symptoms, and also pharmacological management like with your proton pump inhibitors. See, proton pump inhibitors and H2 blockers and antacids and the mucosal protective agents. So these are the available drugs right now to use in the different categories of our acid peptic disorders. So they include gastroesophageal reflux diseases, simple gastritis, duodenitis, esophageal ulcers, gastric ulcers, duodenal ulcers, and Zollinger-Ellison syndromes. See, GERD is a very common among the acid peptic disorder patients in India. The significant proportion of the patients with the APD are reported to have the GERD, indicating its commonness. And GERD prevalence is very high, it's about 10%, which significantly affects the quality of the life. And the gender distribution, erosive and non-erosive GERDs are more common in the females. So males to female ratio is about 1:2. And age distribution, the most common age group observed here is a 35.7% between the 18 to 39 years of the age group, and 34% between 40 and the 60 years of the age group. So the clinical profiles of the acid peptic disease and GERD in India presents like the common symptoms like heartburn, so which is about 55%, and regurgitation about 11%, epigastric pain about 14%, bloating and the irritation about the 16%, and sleep disturbances about 6%. So these are the common symptoms of the GERD, not only always the regurgitation or the heartburn. So the epigastric pain, the bloating, irritation, sleep disturbance is also very common in GERD individuals. See, the profile of the patients with the acid peptic disease, the GERD about 40%, and dyspepsia about 25%, and peptic ulcer disease 16%, duodenal ulcers 10%, and the gastric ulcers 10%. There are certain challenges. Examination and the treatment is challenging. Then the treatment of the PPAs is a standard treatment option in GERD as well as the dyspepsia. Managing the treatment resistance, so the refractory ulcers which require can be treated with the prolonged PPA uses. Over diagnosis and over treatment of the GERD. So in case of the esophagitis, continuation of the PPA therapy is also recommended. So GE disorders are very common and affect the quality of the patient's life negatively. Conditions like dyspepsia, abdominal pain often show the overlap with the acid peptic disorders, complicate the diagnosis and the management. APD is very common and encapsulates many conditions including the GERD, gastritis, gastric and duodenal ulcers and other hypersecretory states. GERD is one of the most common conditions in the spectrum of the acid peptic disorders. Other significant clinical profiles include the heartburn in GERD and epigastric pain, significant disease overlap, treatment resistance, and overdiagnosis of the GERD are some of the challenges in the management of the gastrointestinal disorders. So the final solution for all these ulcers and GERDs, etc., is the proton pump inhibitors. The journey of the proton pump inhibitors starts way back in 1960. So the gastrointestinal research division established to develop a patented drug. And in the 70s, the inhibitors of the proton pump were developed, a long-lasting duration of the action. And 88, the first PPI omeprazole was launched in 1988. So omeprazole became the new approach for the effective inhibition of the acid secretion. See, earlier, now before the era of the omeprazole, so a lot of the cases they used to, that of the people, they used to have the pyloric stenosis and also complications of the gastritis and the gastric ulcers and the duodenal ulcers. But thanks to the omeprazole, which has launched in 1988, there was a lot of the improvements in the quality of the life of this population, and almost the surgical correction like the pyloric stenosis correction is now almost very minimal, very negligible nowadays, because now the gastroesophageal disorders or GERD is totally a medical condition, so no surgical interventions at this juncture. See, it recognized as the first clinically useful PPI omeprazole, demonstrated the consistent patient tolerance, excellent safety, and superior acid suppressing capability than the earlier agents. Steadily became the mainstay in the treatment of the acid-related disorders. See, as I told you, it was first introduced for the clinical usage in 88 and 89. Omeprazole in the duodenal ulcer and the gastric ulcer. Remission of the duodenal ulcer maintained with the 20 milligrams of omeprazole daily. Omeprazole in the NSAID-induced ulcers, effective in the prevention and the treatment of the NSAID-associated ulcers. So those people with the connective tissue disorders, those people with osteoarthritis, those people on the steroid therapy. So we always use the omeprazole like proton pump inhibitor to reduce the incidence of these GERDs and the peptic ulcer diseases and gastritis. Inhibits the growth of the Helicobacter pylori at a low pH and in the absence of the urea. Healing and the symptom relief of the esophagitis, we use the omeprazole in the GERD. See, this is the acid peptide and has been used safely for over the 32 years. It is a well-studied drug. Effectively treats all acid-related disorders, and a lot of the researchers, the most researched PPI in the world right now is the omeprazole. See, highest number of the FDA indications. A short-term treatment for the peptic ulcer heals within the 4 weeks. Duodenal ulcer disease and Helicobacter pylori infection, gastric ulcers in the adults. GERD in both the pediatric and adult population. Healing erosive esophagitis in both the adults and the children. Uncomplicated heartburn. And conditions like a Zollinger-Ellison syndrome and multiple sclerosis, etc. So we use the omeprazole. And move on to the S-omeprazole. It was introduced and several compounds were tested to identify the PPI superior to the omeprazole in 90. So esomeprazole, they got the FDA approval in the year 2001. Indications for the treatment of the GERD, for the risk reduction of the NSAID associated with gastric ulcer, H. pylori eradication to reduce the risk of the duodenal ulcer recurrence, and pathological hypersensitivity conditions, including the Zollinger-Ellison disease. What led to the FDA approval for the esomeprazole? It blocks the final step of the gastric secretion and produces the dose-related sustained inhibition of the basal as well as the stimulated gastric acid secretion. See, effective in controlling the heartburn symptoms, comparable healing rates in erosive esophagitis, better rates of the symptom resolution, offers a greater clinical efficacy than the other PPIs, highly effective in the maintenance of the healing and the erosive esophagitis, and acceptable safety profile. So if you see this, there is all the FDA approved indications. So that is the reason esomeprazole is very popular and very effective in reducing the heartburn and improving the healing rates and also symptomatic relief and also clinical efficacy and maintaining of the healing processes and good acceptable safety. So this is the enantiomer study. Omeprazole was a racemic mixture of S and R isomers in the 1:1 proportion. So esomeprazole was developed from this racemate. The clinical benefits of this S isomer is the higher metabolic stability, resulting in the more consistent bioavailability. Metabolized slowly, leading to the more effective control of the gastric acid secretion, even after a single dose. And inter-individual variation and no need for the dose adjustments due to the satisfactory metabolism of the esomeprazole. See some of the pharmacokinetics and the pharmacodynamics of the esomeprazole. Metabolism advantage, so higher plasma concentration, leading to the improved intragastric pH profiles. Superior acid suppression, so outperforms other PPAs, higher 24-hour median intragastric pH and maintaining the intragastric pH more than the 4 for at least 12 hours a day. Identical dose response curve to the omeprazole. Highest bioavailability, twice daily dosing for the optimal effect. Due to the shorter half-life, twice daily dosing is recommended for maintaining the reasonable plasma levels of the drug. So these are the advantages of the esomeprazole because of its metabolic advantage, superior acid suppression, good bioavailability, and some cases we can use even twice a day also. So the proton pump inhibitors is the mainstay treatment for the GERD. Esomeprazole, that is the S isomer of the omeprazole, higher metabolic stability and lower variability, was launched in 2001. Indicated in the treatment of GERD, gastric ulcers, reduction in the ulcer recurrences, pathological hypersecretory conditions such as the Zollinger-Ellison. It has a higher metabolic stability, resulting in the consistent bioavailability, more effective acid secretion control, lower inter-individual variation and no need for the dose adjustments. The two isomers have same physicochemical properties and have shown same dose response curve with superior bioavailability and better gastric acid inhibition. So let us spend some time on the testimonies of the esomeprazole. This is the global positioning. The new PPI as the market leader became the best seller in 2010, proved to be a promising therapeutic agent in the latest systematic analysis, reported to have the higher potency in acid inhibition than other PPAs, ranked first among the different PPAs for healing, relief of the symptoms and tolerance. So there are about 98 RCTs, nearly the 45,000 patients. Esomeprazole at a full and standard dose of 40 milligrams per day was most efficient in healing among the different drug doses. And it is recommended as the first line short-term therapy in GERD for healing in the dose of 40 milligrams per day. It is, as I told you earlier, that it is ranked as the #1 PPAs because overall Sukra ranking inputs the esomeprazole as the first for efficacy, safety and tolerability, whereas the pantoprazole at the 4th rank. Clinicians can consider esomeprazole as a preferred choice for the optimal GERD management. Outcome didn't change after adjustments for the area or age or level of the disease from the endoscopy. See that the two objectives, one is the primary efficacy outcome and the secondary efficacy outcome and the acceptability of the treatment. So it shows you the healed esophageal erosive esophagitis is healing is good, and there is a complete resolution of the heartburn is also seen. Esomeprazole versus other PPAs, it's a better healing with the esomeprazole 40 milligrams, about 46% healing at 4 weeks and about 58% at 8 weeks. Highest probability for the heartburn relief, nearly 86%. Superior to other PPAs in the mucosal erosion healing and heartburn relief. Improved efficacy. See, large RCTs, faster relief with esomeprazole versus the pantoprazole, nearly 3,000 patients, 8-week therapy with esomeprazole 40 milligrams and pantoprazole 40 milligrams in the management of erosive esophagitis. And if you see the comparison of the healing rates with esomeprazole and the pantoprazole, at 4 weeks, 81% with esomeprazole and 75% the pantoprazole, whereas at 8 weeks, nearly 96% with esomeprazole and 92% with the pantoprazole. See, esomeprazole 40 mg is more effective than the pantoprazole for healing the erosive esophagitis and providing resolution of the associated heartburn. See, better healing and symptom resolution, efficacy and tolerability in healing erosive esophagitis and resolving GERD are more beneficial in healing. Study conducted in the 163 centers in US with the 2,425 patients. They have given the 40 milligrams of esomeprazole once daily for 8 weeks. So they show a sustained resolution of the heartburn at 100% of the patients and high concurrence between the healing of the erosive esophagitis and resolution of the gastroesophageal reflux diseases. See here the 274 patients with the reflux esophagitis, 8 weeks treatment with the different PPAs once daily, and outcomes, daily changes in the heartburn and acid reflux symptoms, mean heartburn score, and trying to complete the resolution of the heartburn. See, let us see. Here the daily change is the mean heartburn score for all subjects. So they compared the esomeprazole, pantoprazole and lansoprazole. And daily changes in the mean heartburn score also. So significantly lower heartburn score in patients treated with the esomeprazole. In the faster decrease in the heartburn score treated with esomeprazole when compared to the lansoprazole and the pantoprazole. And if you see the 24-hour intragastric pH profile, there are about 34 patients experienced the heartburn were randomly assigned to have the 5 treatment sequences. The drug was taken on the 5 consecutive days, and each treatment phase was separated by a washout period of at least 10 days. See here the crossover study, 1.4 times long-term relief from the acidity versus the pantoprazole. See, esomeprazole scores over the pantoprazole and mean number of the hours for which the gastric pH, intragastric pH more than the 4 for 14 hours for the esomeprazole, whereas 10.1 hour for the pantoprazole. So esomeprazole provided more effective control of the gastric acid than the other PPAs in patients with the GERDs. In the same way, the 25% more patients treated with esomeprazole compared to the lansoprazole and 35% more compared to the pantoprazole has the intragastric pH more than the 4. So productivity variables before the treatment and after the treatment, absence from the work, so there was an improvement in the esomeprazole group, reduced work productivity, there is an improvement in the work productivity, and reduced productivity in the activities, there is also an improvement. So esomeprazole significantly improved the work productivity and reduces the GERD symptoms. So here the population of the Helicobacter pylori infections, treatment is not specified but comparison, esomeprazole based versus the pantoprazole. Esomeprazole based triple therapy showed the higher reaction rates versus the Helicobacter pylori to pantoprazole therapy. Then the patients with the GERD, again the lower rates of the heartburn and the epigastric pain with the esomeprazole. Patients with history of the GERD, control of the heartburn symptoms is good with esomeprazole. Patients with the chronic GI symptoms, esomeprazole is significantly effective than the placebo in maintaining the relief of the upper GI symptoms. Patients with the GERD grade A, B, C, the esomeprazole provided a significantly greater healing after the 4 weeks. Proportion of the heartburn free days similar. So the safety and the drug interactions, systematic review and the meta-analysis involving 4,495 patients. No significant difference between the esomeprazole versus other drugs. Higher serious adverse event risk after other drug treatments. No potential interaction of the esomeprazole with other drugs, especially the diazepam, phenytoin and warfarin. Limited adverse events in combination with the amoxicillin and the clarithromycin. Long-term safety analysis indicates the tolerability and even it is safe in the pediatric patients. So these are the differences between the esomeprazole and the pantoprazole. If you see the intragastric pH maintained more than the 44 hours, more than the 4 intragastric pH, 14 hours in the esomeprazole versus the 10.1 hour in the pantoprazole. Ulcer healing rate at 4 and the 8 weeks. So 40%, 46% higher at the 4 weeks and 58% higher at the 8 weeks. Heartburn relief, good with esomeprazole. Esophagus healing rate at 4 weeks, more with esomeprazole. Esophagus healing rate at 8 weeks, again the more with esomeprazole. So esomeprazole is found to provide more effective control of the gastric acid, dyspepsia and epigastric pain compared to the other PPAs in patients with the GERD symptoms. Esomeprazole has the first SUCRA ranking and hence can be considered as a preferred choice for the optimal GERD management. Esomeprazole could successfully maintain the intragastric pH more than the 4 for a longer duration compared to the other PPAs. It was found to be superior in mucosal erosion healing and faster heartburn relief compared to the other PPAs. A favorable safety profile is noted with the esomeprazole. What are the testimonials for the activation of omeprazole? See the median gastric pH, percentage of the time pH more than the 4, percentage of the patients with NAB. So comparison, so omeprazole taken OD at the bedtime and pantoprazole taken the BD. See the onset of the action within an hour of the administration, maximum effect in the 2 hours. Inhibition of the acid secretion for more than that 72 hours. So they compare the omeprazole 40 milligrams with the pantoprazole 40 milligrams with respect to all the 3 PD parameters. See, faster onset of the action compared to the panto. So quicker activation of the omeprazole, 4 times more effective. It's a multi-center study, about 600 people. So if you see the heartburn, regurgitation, epigastric pain, nausea, vomiting, bloating, so esomeprazole scores for the pantoprazole in all these upper gastrointestinal symptoms. 45, that's the effectiveness of the omeprazole versus the pantoprazole for the symptomatic relief of the GERD and the APD. It's a real world evidence study. Heartburn 4 times effective, significant complete resolution, regurgitation 2 times more effective, and significant complete resolution. So omeprazole is significantly more effective in resolving the GERD than the pantoprazole 40 mg after 14 days of the treatment sustained effect till day 28. Study further convincingly shows that both the omeprazole and pantoprazole are effective in drug-induced acidity, with omeprazole resulting in the comparatively better resolution of the symptoms. Both the PPS are safe and well tolerated. The study reinforces the effectiveness of omeprazole over the panto under the real-world evidences. Efficacy for a nocturnal acid breakthrough management. A trial was designed to compare the IR-OM to pantoprazole with respect to the control of the nocturnal gastric acidity. So it is an open label, randomized, 2-period crossover design with the effect of once daily nighttime dosing with IR-OM on 24 hours gastric acid secretion. A bedtime dosing regimen was chosen for IR-OM to take advantage of its unique immediate release formulation. So single bedtime dose 40 milligrams achieved better nighttime pH control than twice daily dosing with the pantoprazole with respect to all the 3 pharmacodynamic parameters. A single dose of omeprazole 40 milligrams is better than the pantoprazole twice a day in reducing the nighttime pH of these gastric juices. So it maintains the higher gastric pH relative potentiates based on the mean 24 hours. Greater potency, omeprazole helps to achieve the higher mean gastric pH in the GERD patients. See, one of the 5 PPAs are the 4 H2 receptor blockers. There are about 98 randomized control trials, nearly 45,000 people. Result, omeprazole ranked first for the relief of the symptoms. The safe and effective PPA. Adverse effects reported inhibition of the antiplatelet effects of the drugs, such as the clopidogrel leading to the heart problems and the death. Decreased absorption of the mycophenolic acid graft resection is one of the most widely prescribed safe and effective drug models. So use of omeprazole is considered the safe if the patient is not under antiplatelet therapy. It is used in combination with the antibiotics for irritation of the pylori and treat the esophagitis also. So how safe is omeprazole on long-term basis? The multi-center study, 230 study population, patients with the persistent reflux esophagitis, not responsive with H2 blockers, and elderly, not eligible for a surgery. Study duration, 4 years. Intervention, patients were first healed with 40 milligrams of omeprazole, and 40% of the patients took longer than this. Follow-up, at least after 5 years, with annual endoscopic and laboratory examinations. See here the results. Average number of the adverse effects of the treatments for the just 0.5. Incidence of adverse effects was higher in patients more than the 65 of the age group. No marked progression of the Barrett's esophagitis, a severe form of the GERD, which is a precancerous condition. Omeprazole is safe and efficient even in the infants and the children also. So short term less than 8 weeks of the treatment, duodenal reflux esophagitis or the duodenal ulcer refractory to the conventional treatment. Effective and well tolerated in children with esophageal, esophagitis, gastroesophageal reflux disease, and peptic ulcer. In the treatment of H. pylori, duodenal and gastric ulcer, Zollinger-Ellison syndrome, acid-related dyspepsia, and fat malabsorption in cystic fibrosis in the children. Long-term treatment up to 11 years is effective and safe for the control of the severe esophagitis in the children. So effective management of APD symptoms based on the severity. Omeprazole, hyperacidity symptoms like heartburn, epigastric pain, regurgitation, nausea and antibiotic-induced hyperactivity, whereas esomeprazole for dyspepsia, abdominal pain, GERD, and severe hyperacidity symptoms. Thank you very much for your patient hearing.